All right, welcome everybody. Thank you so much for joining us today for our webinar on achieving strategic growth through CCM and ancillary services. My name is James Muir. I'm going to be your host today for this session. We're thrilled to have you with us, and we're looking forward to a very engaging and informative session. Before we get started, let's just go over a couple of housekeeping items just to make sure we have a good experience for everybody. Everybody in this session is muted during the presentation in order to minimize background noise. And we are going to have a dedicated Q&A session at the end of the presentation. So there's a Q&A feature here in Zoom. So you can open that up and you can submit your questions during the presentation. It's a hot topic, so I promise you we'll do our best. If we can, we'll incorporate your question right during the presentation. If we can, if not, I promise at the end we'll cover it and we'll do our absolute best to address as many questions as possible. This session is being recorded, so it will be made available to everybody who registered for this session. And you're going to get an email with a link to that recording along with some additional resources that we'll talk about during the presentation. So without further ado, let's dive into the topic. And right now, everybody is looking for ways to improve practice revenue right now. And because CCM and RPM is just such a hot topic right now, I thought, man, who can we invite to educate us on this topic that's going to be the absolute best? And that person is Dan Unievsky, who is the director at Insight Health. So join me in welcoming Dan. He's an expert in chronic care management and remote patient monitoring and improving practice revenue in general. And so for those of you who don't know him like I do, Dan Unievsky is director of partnerships at Insight Health. And he is constantly driving strategic collaborations to help expand access to RPM and CCM for providers to improve patient outcomes, but also to optimize practice revenue. And I don't want to steal any Dan's thunder before he gets started here, but our clients have averaged somewhere between 80 and 100 grand annually per doc using their services. And so I would call Dan sort of this unique blend of strategic communication along with sort of a results-oriented mindset. And so I thought, man, that is going to be perfect for our session today on improving financial results for practices. So you're going to see right away that he's a wealth of knowledge. So enjoy your time with us today. Dan, thank you so much for being with us.
Yeah, thank you so much, James. I want to extend my gratitude on behalf of myself and the rest of the Insight team to not only be partnered with you and Unislink, but all of the amazing individuals on your team that constantly work with us to optimize not only the services for your providers and their patients, but even on the back end as we work together on the billing and the claim side of things to make sure these programs are successful, to really optimize that clinical and operational efficiency for all these types of providers, as well as everyone in the audience. Appreciate you taking the time to join James and I today as we discuss what the landscape looks like within chronic care management, and happy to really start diving in a little bit deeper here about today's conversation. But James, thank you so much for having me join today.
Yeah, we're so excited to have you. So let's dive right in.
Absolutely. So as far as the landscape goes today, I do want to first start off with the agenda that James and I had outlined about really talking about what's going on with remote care in the industry that we're in, a little bit more about Insight and the services we can provide, and giving a high-level overview of how we can assist not only these providers, but their patients as well, and assisting on treating and improving the outcomes that they're suffering from these chronic conditions, as well as highlighting how the EHR integration and billing components work to make sure these programs are successful on the back end when they do get billed out to Medicare and commercial payers. But then ultimately making sure we emphasize the impact it's going to have on the patients, as well as the financial implications for the clinics that we provide these services to. And then, as James mentioned, we do have a Q&A panel where you could put in your questions as we go through the presentation, but even after we're finished, happy to answer any further questions that need clarity. But as far as the current landscape today, 60% of Americans right now have at least one chronic condition and 40% have two or more. So how this translates to chronic care and remote care overall is that what we're finding right now, the adoption rate is still extremely early. There's only 4% of patients who are actively enrolled into an RPM and CCM program today. So that's where James was mentioning, even the providers that are with Unislink, they're probably seeing huge changes in their patient population where chronic diseases are growing year over year, but then it's making it more difficult for providers to not only manage and treat these patients, but keep them accountable when they're outside of the clinic to prevent these conditions from getting worse and growing as they have. That's where we want to come in as far as providing the what we like to call patient care intelligence service model, where we're going to be covering the entire care spectrum for providers. The specialties we've been working in that have the most impact on treating and alleviating these chronic conditions are going to be primary care, cardiology, nephrology, pulmonology, and endocrinology. We're not only going to be delivering remote patient monitoring devices and chronic care management services, we're also going to be assisting with the principal and transition care management of these patients, as well as even having behavioral health integration components where patients within these disease populations are suffering from chronic depression and stress, anxiety. So there's opportunities for us as care coordinators to really assist these patients in helping treat the conditions that they're suffering from. And as James probably even mentions to us on a daily basis, how stretched thin these clinics can be, we have additional services where we can step in and alleviate some of that workload for the clinics by offering annual wellness visits and doing social determinants of health assessments. As far as where we're at today, I know some people are still a little bit newer for remote patient monitoring, and the devices have been around, but as far as what it is we are actually deploying devices that can continuously monitor and manage chronic conditions. I will show all the devices that we can provide, but ultimately something I'd love to highlight is the fact that our devices are enhancing patient engagement, but also providing timely interventions where we can have early detection and better outcomes on treating the conditions that they're suffering from. And then even on the chronic care management side, this is where patients who have two or more conditions can be assigned a care coordinating nurse, whether that's an RN, nurse practitioner, or LVN, where we can have a much more holistic approach, but a much deeper connection with the patient, where we have scheduled monthly calls with them to really ensure we're developing the best care protocols and care plans to put them on a path of success and accountability. So when they're outside of that clinic setting, the providers know that their patients are being taken care of. The dilemma right now that we're finding with providers and how healthcare is transitioning is there's the fee for service and value-based care initiatives that are pulling them in multiple directions. The health of their patients in these populations are drastically declining year over year, which makes it harder, even on the provider side, to keep these patients accountable. But then ultimately, I think the elephant in the room too is that reimbursements are dropping for physicians constantly. So not only are they looking for ways to improve patient outcomes, but I know they're speaking with the Unislink team on a daily basis of what else can we be doing as a clinical operation to not only optimize and be more efficient with the financial health of our operation, but identifying new reimbursements that we could bring into the practice so that we can continue growing and scaling our operation. As James mentioned, the average physician that we're working with Unislink is generating six figures in profit per physician per year. And with our model, the way we've established it is chronic care management and remote patient monitoring have significant impacts, but they are quite costly to stand up. And that's why it's been a little bit slower for providers to bring on this initiative, because the financial investment can be quite substantial, not just only the devices, but even having the nurses on staff to monitor patients and perform these assessments and constant readings and working with the patient. So with us, what we do and provide to the clinics that we service is there's no upfront cost to get started. Our program does not have any subscription fees. The only time we would charge an invoice is if the codes that the Unislink team bills for are collected by the provider we work with. They would compensate us for those reimbursements. So they collect reimbursement, Unislink is working with them, and then we get paid last. But ultimately, what this does is it improves the clinical and operational side on the back end to ensure the providers can truly focus on patient care. The Unislink team has a whole revenue cycle and billing component covered. We're coming in as that remote care model to ensure clinical efficiency with the patients. As far as a little bit more about Insight, we're a team of experts that have been doing this basically since the beginning of the inception of these programs. So CMS started the reimbursement on remote patient monitoring in 2018. In 2020, they started the chronic care management reimbursement. We are operating nationwide, and then we have some of the best on our board and executive leadership team here. So as of right now, we're one of the only RPM and CCM organizations that have a chief medical officer and chief compliance officer. Our CMO came from Walgreens, and he's overseeing population health and ensuring that the clinical standards we provide and deliver to these patients are far premium to what you can find anywhere else. But then on the flip side, Crystal Garrett, who is our chief compliance officer, comes from a deep background in the payer space where we're constantly meeting with CMS and payers to ensure we're abiding to all guidelines within these programs to really protect the patients, but also the practices that we service to ensure we have a bulletproof model to abide to every aspect in adherence to ensure the success of these services. James has been quite helpful with this portion too, but what's exciting is once providers see the impact this can have on their patients and the outcomes, they start asking, what's the next step? Well, the first step would be that we would have to identify that eligible patient population. So what we do is we do get a guest login to the EHR at that clinic. Our team is going to be doing all this work. Our biggest mission is to lower that workload for the practices we service, so they do not have to hire any additional staff. We're going to come in, we're going to look back 12 months of patients who have eligible insurance and have at least one or two of these chronic conditions you see on the screen here. Once we identify that eligible patient population, we're going to come back to the provider, show them that entire list so that they can decide who they want to keep on that program to have outreach and who they want to ensure can actually do enroll on the services. When we begin the enrollment process, the providers do give a green light prior to this starting. We copy the caller ID of the clinic that we're servicing so that when we do reach out to the patients, this establishes a higher level of trust, knowing that it's coming from the clinic, because the way we're viewed is that we operate underneath general supervision of care with the providers we work with. So we're truly an extension of the clinic. And then we're calling on behalf of the physician to these patients so that we can educate them on the benefits of these programs and services that are going to not only monitor their chronic conditions, but our biggest goal is help improve and alleviate these conditions for them. This is all on a recorded line so that once we are explaining all the aspects of the services and the patient's insurance, we're also making sure we're upholding our good reputation guarantee so that providers can always cross-reference every interaction we have with patients. And then also on a compliance aspect, this helps us keep everything secure for any aspect of an audit that would arise, because once we have a verbal consent, it is on a recorded line, and that allows us to transition to the next step in the process. Every patient who does enroll into these programs, especially on the RPM side, they're going to receive two of our devices. The first one is going to be this white patient hub that you see on the left-hand side. This is our transmitting device that can communicate the vital signs that are taken from the devices, but also is a daily reminder for their patients to take a reading. So each day it's going to have a red ring in the middle to remind the patient to take their reading. It will turn green once they press the button so that they know and are reminded that I took my reading, I'm good for today. Depending on the chronic condition, of course, we will assign that specific device that is most applicable to which condition they're suffering from. I want to emphasize with our model as well, we are paying for these devices. There's no out-of-pocket cost to providers, no cost to the patients. So even the consumables, so if we have to replace a device, replace the batteries, replace any charging cables, testing strips, or lancets, fully covered by Insight. These are all FDA approved, and since our average patient age is around 70 years old, they're basically dummy proof and ready to go from the box. There's no Wi-Fi required. They work off the cellular network, so we have always a live feed of transmissions that come in once they take their reading. Our nurses do reach out to the patients when the device arrives to their home so that we can conduct test readings to ensure the device is working, but also educate the patient device. Once we're up and live with these devices and the patients, we have our own we can do at the practice. So we're collecting all the SOAP notes, clinical documentation, vital sign data, and then ultimately making sure that's readily available for the providers to cross-reference and be aware of every reading that comes in, whether it's normal, critical, or alleviated readings, because we do have a clinical and escalation protocol in place to ensure that if there's ever symptomatic patients, we know how to escalate that accordingly. This is where I want to come in and highlight the amazing work that the Unislink team does, because all of this work, the cherry on top is not only that patients are having a better quality care program to help alleviate their symptoms, but this is all reimbursable back to the payers and Medicare, Medicare Advantage. And that's where Unislink has been assisting our and the practices that they work with to ensure that billing is streamlined. These are some of the codes that are going to be generated. This top row is for remote patient monitoring, and chronic care management is on the bottom row. If everyone notices, the thing I'd like to point out is, yes, it is labor and time intensive to make sure these programs are successful. That's where we take great pride with us, because everything we have is in-house. We do not outsource any of our employees. So our enrollment specialists are in-house. Our nurses are located in the United States. They're going to be credentialed in that state where they are treating and managing patients. But then ultimately, we have the team to scale this program to achieve the highest level of time threshold per month with each patient who is enrolled, because it does actually get billed for by 20-minute increment blocks. But as far as a monthly billing report, prior to explaining a little bit about this, James, I'd love to pass it back to you to let the audience know how much of an incredible job the Unislink team is doing on a billing perspective, not just as the total practice goes, but even the RPM and CCM side, on how efficient it's been and the experience you've had.
Sure. Well, what our team does is collect the information that you guys need on your side and send that to you. So that's a very high level, but for the most part, the whole program, if I could characterize this compared to some other, we have clients that have participated with lots of, they could try to set up their own chronic care management programs. They've tried other vendors. Most of this is just completely headache free. You basically, Insight does all of their work, and then on the billing side, we send what they need. So you're kind of out of the loop. You just basically, it's almost like having passive income. So it's easily the best of all the vendors that we've experienced for our clients. And by the way, I have a whole ton of questions that have come in. So I'll let you keep going, and then we can save them to the end. I don't want to throw you off your groove.
Yeah, no, absolutely. I appreciate that. And then just as reassurance too, everything we do within our program and software is recorded, timestamped, and documented so that every clinical encounter can be referenced. This is actually allowing us to optimize the entire operational workflow to ensure we have a secure audit trail that's readily available to Unislink and the clinics that we are servicing, to ensure that everything is documented and available for them to reference.
Yeah,
But
this might be a good minute to just to mention.
yep.
The reason that we do these types of webinars is anything that improves a client's revenue cycle is good for both us and for the client, right? Due to the nature of our agreement. So this is one of many different types of revenue enhancing opportunities that we present to our clients. If it's a great match, we hope that you'll take advantage of it because it's good for everyone. So anyway, sorry, keep going.
Thank you, James. And as I mentioned, our biggest model is not only upholding a good reputation guarantee, but within our agreements and the service line that we deliver, we want to minimize all risk, whether it's clinical and even financial. So as I mentioned at the beginning of the conversation, all of those CPT codes that are going to be processed and claimed for reimbursement to the providers, if any of the codes are stuck in pending or denied or whatever it might be, we do not charge on any aspect of our service unless those providers have collected reimbursement. So we are essentially putting our money where our mouth is to ensure the programs are successful, but we've removed and lowered entry for the providers to enter into these programs. Something I'd like to emphasize as well is the guidelines right now that have been established, they only allow a patient to enroll with one provider for RPM and CCM. So that's the daily risk providers are unaware of, that the longer they delay having an RPM and CCM program puts them at a significant risk of losing their patients being enrolled to either a PCP or a specialist, depending on what type of provider that is. And once that happens, there's nothing that can be done, unfortunately, due to the guidelines that are set in place. So not only do we want to ensure the providers are educated about these RPM and CCM models, but whether it's with us or a different vendor or themselves, it's not a matter of if they're going to have a chronic care program. It's a matter of when they're going to start offering it to their patients, because that's the future of where healthcare is going, especially as these chronic diseases continue to grow and expand. From a success story, though, the patient impact is quite substantial, but the financial implications for the clinic is that this is going to be a new revenue stream for them. And ideally, we've built this to be as passive as it can be for the clinics and their staff, so they do not have to worry, ideally, about anything with it. They don't have to hire additional nurses. They don't have to hire any additional staff at the clinic. But the reward on this investment for them on offering CCM and RPM to their patients is the upside of the financial aspects that can help them grow their clinic. So this is an example of a practice we have in California. It's a single physician, primary care internal medicine doctor who has patients on multiple devices, but they are able to bill out all these CPT codes. And as you see here, the profit after fees have been paid for us and Unislink and their entire model, they're taking home $25,000 a month in additional profit. But ultimately, they're helping over 450 patients on a monthly basis to improve the chronic condition that they're suffering from. But as this can scale and put it into perspective, even on different size clinics, such as this multi-provider clinic where there's 3 physicians and 3 nurse practitioners, as you see here, they have over 1,000 patients that they're able to help alleviate their symptoms, but then ultimately collect these new reimbursements where they're bringing in over $60,000 a month in profit, which is just over $700,000 a year for their clinic, so that they can continually invest in better equipment, better office space, whatever it might be that can help them expand their operation to better treat and service their patients. And the reason this movement is happening specifically in value-based care is these statistics here. So the way CMS and commercial payers are looking at these programs is the substantial impact it has on the back end of the entire healthcare ecosystem, because when we do have patients enrolled, we are finding that we're able to reduce hospitalizations and reduce emergency room visits, but ultimately improve these preventative care aspects to ensure that we can get patients off medication, we can prevent them going to the ER, and then ultimately with us too, it's driving a better engagement with their provider and even our nurses, so that the patients are held accountable, but then they have that lifeline and extension to our team, so that we can basically be their care coordinator that's even assisting with building nutrition plans, scheduling appointments at the clinic, helping find free transportation for them to arrive to the clinic for their appointment as well. So think of us as the premium concierge service that's really ensuring that the patients are well taken care of when they're outside of the office. And as we wrap this up today, we actually have a QR code, so we can actually tailor a presentation a little bit more specifically to the specialty you're in, the types of patients you're seeing, what state and county you're located in, so that we could bring in the more specific projections as how much this will impact your patient population and the financial health of your clinic. But I appreciate everyone's time, and James would love to go over some of these questions so that we could provide some more clarity.
Sure. I have a couple of selfish questions I'm going to ask first.
Yeah,
Let's keep the QR code up just in case they
absolutely.
want to shoot it while we're doing questions. But so first, selfish question one. So nobody asked this but me. Let's talk about the payers for a second. So
Yep.
what type of payer mix should a clinic have, or look to have, in order to be able to get compensated for CCM and RPM?
Yeah, absolutely. So the payers, it's going to be Medicare, Medicare Advantage, and then on the commercial side, Cigna, Blue Cross Blue Shield, Aetna, Humana, United. So the big payer mixes. And the beauty with our program is since we are doing all that work on behalf of the clinic and their staff, when we do identify the eligible patient population, we're cross-referencing all of their insurance as well, so that when we bring that final list of eligible patients back to the providers, they will know exactly who can be enrolled and the implications on the payer side of things to know that there's reimbursement that can be collected.
Hey, I noticed you didn't mention Medicaid. So is Medicaid not a good, if they have a high percentage of Medicaid, is this not a good candidate for them?
Medicaid can be done. There's different aspects to it where we like to evaluate depending on where the practice is located. So we're happy to evaluate it, but there's been higher success in Medicare, Medicare Advantage, just from the reimbursement perspective. But what we're finding is that majority of these patients at these clinics, at least half of them have a secondary insurance. So that's the beauty too, is there can be additional coverage that can pick up costs on the patient side.
Okay. Yeah. Well, obviously a demographic difference usually between Medicare and Medicaid.
Yep.
All right. So this question number two, and then I'll get to the ones that people have sent in.
Okay.
So what kind of compliance issues, that does a practice have to worry or think about, or regulations they need to be concerned with when they're implementing one of these
Yeah.
CCM programs?
Yeah. So from a compliance perspective, what we've done is we've built our model brick by brick from the independent providers that we've been working with. So from a clinical adherence perspective, our compliance team is always ensuring we're abiding to all the guidelines for RPM and CCM to be successfully built out. And then even on the back end, once we are doing the clinical work and spending time with these patients, taking their readings, everything is going to be recorded, time-stamped, and documented within our software so that we can have that readily available if there is an audit that arises. So our dashboard has all of that information for the providers to cross-reference. So compliance is fully covered and essentially bulletproof to ensure that from a regulation perspective, this program is going to be successful from day one.
Okay, so I'm going to restate what you said just for the benefit of everybody on registered here. So there are no additional compliance or consideration issues that the practice has to concern themselves with. I mean, you've got that all covered. If they adopt the program and they're doing it through you, you're essentially taking responsibility for all that piece.
Correct.
Is that what I heard?
Yep.
Okay.
Yeah.
All right. So let me get through some of these other questions here. That this means they're not going to follow any particular order. Sorry. So one of the ones we got in here, it says, we tried this and bombed a year ago
Mhm.
because it's hard to set up devices. What's the
Yep.
best way to address that?
Yeah, so I would be curious if that clinic was doing it themselves or if they were using a vendor. I would love to highlight how we do it a little bit differently. So we deploy those devices. We cover all costs of device and shipping, making sure it arrives to the patient's home. Our nurses are reaching out to those patients to educate them on how to utilize the device as well as making sure it's working properly. So that's where we can come and step in to not only provide that hands-on training, but then even the scalability of making sure there's enough devices available to the patient population at that clinic. So we have all aspects covered from service, device, costs to really alleviate the headache that the practice would encounter if they tried doing it themselves or if there's a vendor that they're utilizing that doesn't really have the fully vertically integrated process such as we do.
Okay, I think I got to follow up. It's probably from the same person, but I can't tell. But
Mm-hmm.
the question is we were supplying devices in the clinic.
Okay.
So how does the patient get the devices when they're using Insight versus maybe you know, other
Yeah,
guys?
so we can do multiple models. I mean, even we could supply the clinic with devices. So we love a teamed up model too, where even having a on-site liaison that we cover the costs for, depending on the size of the patient population. But we can supply the clinic with devices so that if they enroll a patient, we can have it available. But we actually ship those devices directly to the patient's home. So we will deploy that to the patient directly.
Gotcha. What's more common?
Yep. It's shipping it to the patient's home has been more common.
Right. Okay. All right, next question here. This person said that these programs sound very complicated. What goes into actually creating a CCM program? What are the steps the practice has to take?
Yeah, as far as the complicated model, we've tried making it as simple as possible. So the the eligibility criteria for chronic care management is a patient having 2 or more chronic conditions. And then once we identify those patients and we could get them enrolled, our care coordinating nurses are the ones doing all that clinical work on the back end. So from a practice perspective, the biggest thing is just the initial work of confirming the patient list that they want to enroll. And then once we have clinical protocols and escalation protocols in place, we're doing all this back end work to monitor their vital sign readings. And then depending on what type of reading we receive or what chronic condition we're monitoring, we know how to handle that properly. But even if there's escalations needed, where if we have to reach out to the clinic directly, or if it's a severe and critical reading, we have to dispatch 911, we have everything in place. So even for instance, we have a cardiology office. It was about a month ago, we had a patient who had a 220 over 130 BP reading. Our nurse called out to the patient within 30 seconds of us receiving that reading to confirm if everything was okay. We stayed on the line with the patient, tried taking another reading, but we did have to dispatch 911. We did stay online with the patient, even though they were saying, I feel fine, nothing's wrong. We did later learn that the patient, when they were taken to the hospital in the ER, they had to undergo emergency surgery. They were having a major heart attack. So, with our intervention, that's where the complication is basically removed, because we have our nurses on staff 24/7, making sure these patients have full oversight on whatever chronic condition that we're treating and monitoring for them.
And that is literally the reason why you're doing the program, right? Is to provide better care. So a tragedy averted there in a case like that. I feel fine. I feel fine. And then later you're doing surgery.
Yep.
Um, okay. Selfish question number two, right? So I got more questions. I want to insert one here.
Mhm.
So I've seen this with actually quite a few vendors. I've seen it with different practices trying to stand up a program.
Mhm.
And where it usually seems to bomb is
Mhm.
in the enrollment side.
Yep.
So can you just kind of speak to how do you guys go about enrollment, getting enrollment up so that it creates both the care improvement for the patient panel as well as the revenue for the practice?
Yeah, absolutely. So, how we do enrollment a little bit differently than some of the other vendors, our whole enrollment team is in house. So, we do pay above market rate to ensure we're bringing in clinical experts that are going to have even certain qualifications as even being bilingual, because depending on what states we service, we want our enrollment specialists to not miss out on that patient population if we do have another language that we have to speak to those patients. So that's one aspect, is the staff that we're bringing on is going to be at the highest level from a clinical perspective and the speaking perspective. But then from the list that we've identified, and even the model of replicating the caller ID, educating the patients that, hey, this is on behalf of the physician, we have partnered up with them to help provide these services to you. We're achieving between a 50 to 60% telephonic enrollment alone. And then, as I mentioned a little bit earlier, if the clinic has 300 or more eligible patients, we can actually staff an on-site customer liaison that will help manage this program for the clinic at no extra costs to the
So
providers. So that person will actually be, think of them as the buffer, because there are going to be patients calling in confirming, hey, is this service real? I had this phone call, or if there's device issues or if there's questions, our on-site liaison can help field all those types of questions and different aspects that the patients can bring back to the clinic. But then on top of that, that individual also will be assisting with maximizing enrollments, because there usually is a delta of patients that have not enrolled. Might be difficult for us to get a hold of them over phone or outreach. So when they are coming into the practice, we have that individual that can educate those patients in person and then do on-site enrollments as well.
so that sort of makes me wonder, what's that sort of threshold at where, this is absolutely worthwhile doing, and where if the number of eligible patients, we'll say, is too
Yeah.
low to make it worthwhile? What's that? You want to take a stab at what number
Yeah.
it would?
So, I mean, with us, we want to treat every patient possible. That is our biggest mission, is putting the patients first. But from a service model, it could be costly to get this up and running. So as long as if a practice has at least around 100 patients for the program, then there's no issues to get this up and running. we're never going to turn away a practice. We would always love to come in, provide an analysis, and evaluate to see how many patients they truly have eligible that we can enroll. So we will not turn them away. But ideally, it's like if you've had over 100 patients that you've seen in a year, by all means, this is going to be an incredible program for you.
All right. So even a startup, I mean, like everybody has 100 patients.
Yep.
So is there even within certain, let's just use Medicare.
Mm-hmm.
If within Medicare, only 100 patients it still makes it worthwhile, or are there certain Medicare
Yep.
patients that really aren't eligible for this?
So if it's 100 in Medicare, then perfect. That's a great starting point. Even just that population alone can have substantial impacts on patient outcomes, but even on the financial side for the practice for adding a new revenue stream from this.
All right, I got you. I think we half answered this question, but this person asked, how do you get patients enrolled, which I think we already addressed, but
Mhm.
uh, and they said and re-enrolled, by the way. And then how do you ensure patient compliance on their side? And I think
Yeah,
you've
so
already addressed that briefly in your presentation, but maybe you could talk to that a little bit.
Yeah, even on the patient adherence, we have nurses that are constantly scheduling calls, doing outreach with patients. We even use AI applications that can help with adherence just to call in to see if patients have taken their reading, and then that can actually connect them to a live human as well. So if that they have questions, so we are trying to cover basically every aspect of the care spectrum to ensure we have patients adherent to taking their readings and staying compliant to the program to ensure we can actually bill out those CPT codes accordingly.
Gotcha. All right. So this person says, how long does it take to get a CCM or RPM program up and running?
So with us, I mean, at the beginning, once we have a full presentation that we've walked through and providers give us a green light to get it up and running, we usually need a few hours of time to walk the practice through certain aspects of the program, clinically, operationally, billing sides. But to begin billing, we should be able to get patients enrolled within 45 to 60 days. Some practices can actually expedite this process. Last year in October, I had a clinic. We signed up at the beginning of October. We were able to get them live before end of the month. So that's the beauty. Some offices we know are stretched thin, so that can make it a little bit difficult. But typically 45 to 60 days to having patients live and enrolled is what we can do. But there's certain criteria that practice has to do on their end just to make sure we could get the process and the wheels moving forward.
And when do you figure that part out? Just during this sort of when you're getting to know the practice part, that's how you
Yeah,
determine.
so I mean, there's like EHR guest login access we'll need, and going through their onboarding and kickoff calls, training some of their staff on how to utilize our clinical software, making sure they're fully comfortable on the protocols and clinical aspects that will be in place. So the faster we can do that upfront work, which is usually only about a couple hours of time spread out into a few phone calls, then we can start all that back end work on our end of identifying patients, bringing all those patients back to the provider to sign off. So a little bit of legwork up front, but then we can expedite all the back end to make sure we could get this live and start that patient enrollment process as fast as possible.
Okay, well, to summarize, you're saying it's realistic to be able to accomplish all that inside of 2 months.
Correct.
Okay. All right. So this selfish question on my part, and I want to, you can speak generically here.
Yep.
So when people are trying to either implement their own program or when they're just implementing a program, from various other, what are the common things that trip people up or they misstep and then the program doesn't work? What are the pitfalls that people tend to fall into? I'm not saying that this applies to
Yeah.
Insight, but I'm just trying to make our audience aware of where things can go wrong.
Yeah. So, I mean, where things can go wrong is it's if a practice is trying to do it themselves, for instance, it could be a big financial burden to invest in equipment and devices, shipping those. So, even the logistics side of making sure patients can have those devices, even if they have to replace the device or the consumables that go along with it. And then on the flip side as well, from the financial aspect, hiring another nurse or having additional staff that is monitoring and doing the clinical work, because for these reimbursements, they are time based where it's in 20-minute increments. So to have the capacity to actually fulfill the workload on this program is another aspect where this program can fail. So I would say the financial burden is a big part that people get surprised about on standing up this service. But then even from a labor perspective, they're unaware of what they're really getting into to maximize and scale the program to its full potential. So the operational and aspects of there's just not enough time in a day for some of these clinics to have their nurses and their staff doing these programs
Yeah,
for
that's
the
why you
patients.
have someone holding your hand.
Yep.
Okay, so I'm going to broaden this question, but this person selfishly asked, what is the upside for a nephrology practice in implementing CCM RPM? So let me just
Yeah.
broaden. You can speak to nephrology if you want to, but you
Yeah.
want to, does it differ by specialty a little bit, or is it essentially the same across any specialty?
So significant impact across the board for the specialties I mentioned, but on nephrology here, what we could do too is with, for instance, blood pressure monitoring, we can help alleviate and manage hypertension and the risks that can come for patients who have CKD or even glucose monitoring on those CKD patients and weight scales that we provide. So uh, the device is applicable across the board for nephrology practice with these patients who are suffering from, say, CKD or who are on dialysis. So we can monitor those conditions accordingly. But then, even on the chronic care management, our nurses can be those care coordinators and provide the additional assistance to manage these conditions so that the providers have better insight and accountability on those patients. So, huge upside for nephrologists.
Okay. Now, some people I think may have joined us late. Can you restate the specialties that CCM and RPM are best fit for?
Yeah, so RPM and CCM is best for primary care, and then it's going to be like family practice, internal medicine, and geriatrics. And then on the specialist side, it's going to be nephrology, cardiology, pulmonology, and endocrinology. So we've seen these are the most applicable specialties that have the biggest upside benefits on RPM and CCM programs that can be provided and administered to their patients.
Okay, great. Thanks for that. All right. So we just got one more here, which is this person is asking about how these programs fit in with value-based care programs like MIPS and other things. So is there a
Yeah.
connection there? Is there any interaction that we need to know about? That kind of stuff?
Yeah, so there's MIPS and HEDIS measure, so MIPS credits, HEDIS measures. So since we're helping improve patient outcomes and lowering these hospitalizations and ER visits, that's why the value-based care initiative that is in place within healthcare right now is heavily investing into these programs from a CMS and a commercial payer perspective, because they're finding that with the reduction on the back end of even preventing one hospitalization a year with a patient who's enrolled, the financial savings for them is substantial, but then the improvement on the patient care skyrockets. So it's a perfect fit for a value-based care model.
Okay, great. All right. Well, I think we've got through most of the questions. So let me throw one more in here, which is, if someone decides they want to take a picture of that QR code or reach out to you guys, what's that first meeting going to be like with you guys? What should they expect when they finally contact you?
Yeah, first meeting, what they'll be expecting is it's going to be myself, another representative from our team, and then ideally, I'd love to have someone from the Unislink team on that call as well, so that we can not only cover how our RPM and CCM services work, but even from a billing perspective to show these practices that they are well taken care of from a clinical operational model that's happening behind the curtains to make sure this program can be successful. So we will have a tailored presentation for that clinic that will walk through specifically how it impacts their specialty, their patients, as well as even showing them what the fee schedule is for the state and county that they're located in, so that they have an accurate projection on the financial implications and benefits for their practice if they do decide to have this program up and running.
Is there any specific data that they should have with them when you do that first meeting to help prepare them? Or
Yeah,
what?
the data is great. It's not a necessity to join the meeting, but if they have an understanding of how many Medicare Advantage patients they've seen in the last year and how many of their patients have at least one, if not two, chronic conditions, that can help us understand a little bit more about their patient population size and the impact it can have on improving care for that specific demographic.
Okay. Yeah. And by the way, we'll call this a shameless plug. If there's some non-Unislink clients observing this webinar,
Yeah.
we have a free analysis that we can do for you. So if you're interested in that, there is a place on the website to ask for that, but you could just email us if you wanted to and say that you wanted the free assessment. and then that'll help you prep you for this call, for this meeting with Dan a little bit better. But like you said, you don't really need it. That can all happen after the fact, I think. So, Dan, thank you so much. You let me shake you down for 45 minutes. So, I really appreciate that. Again, if they don't have the QR code or they're not QR code people, what's the best way to reach out to you guys? Is there there's no URL on this slide, so maybe you could tell them how to get to your website or something.
Yeah, so our website is insightcare.com. And then by all means, you could go even schedule directly on our website to meet with our team. I can even put out my contact information after this call so that if you want to reach out directly to me, I'm happy to help connect the dots for you and show you a little bit more about our program.
Okay, well, we have some secret people helping us with this webinar. Katie has been helping us do the whole thing. So we'll make sure that the email that comes after this that has the recording of this session in it also has Dan's contact information in it and the Insight way that you can contact them if you want to. But super appreciative that you took the time to be with us. You have done such great work for our clients. So I really appreciate you being able to educate the rest of our clients on the stuff that you do.
No, I appreciate it, James. Gratitude is all on our end. It's great to be partners together and looking forward to the amazing work we're going to continue to do. And everyone in the audience, appreciate the time. Have an amazing rest of the week and enjoy the weekend. Looking forward to meeting with you soon.
Yeah, take care, everyone.
Thanks.